population, hip dysplasia is generally at birth. The head of the, basically your femur, the head of the femur is out of place, out of socket from the acetabulum, or the area of the hip. So you can see here that it's not concentric on this side to where the hip, this is where the ball of the femur would be, and it's supposed to be in good alignment here. I don't have a good pointer, so I'm covering up stuff, but it's outside of the joint. And it seems like in Costello syndrome that actually can develop. It's not always at birth. It also can be missed, and you can have subtle subluxation where it kind of just slowly moves out of that socket, and it's probably due to the loose joints, the ligamentous issues where it just comes out. And if it comes out and stays out, that can cause significant problems with walking, leg-leg discrepancy. And it seems to be fairly common in Costello syndrome. And whether or not it's true hip dysplasia versus just subluxation, meaning the hip just kind of comes out and comes back in, it's a little bit difficult to determine, but most of those have to be diagnosed on an x-ray, and it's just an angle that they measure. And it can be fixed with just bracing, but sometimes they do have to do surgery. Then there's the foot issue, the flat foot. And in the general population, they talk about flat foot, very common in infants. If you take a child, their foot's going to look flat. But that's typically physiologic, meaning it just kind of bends and goes back in place. People who have loose joints will often have physiologic flat feet. In the general population, we usually don't do any treatment. The most common cause of pain is a combination of this hypermobile foot with the tight heel cord. And that's, in Costello syndrome, what I think we're seeing. We're seeing this hypermobile foot, flat foot, in combination to a tight heel cord. And that often will cause problems, whereas in the general population, if you have flat foot, it doesn't cause a lot of problems. But I have pretty significant flat feet, and I almost walk on my ankles. But if you see people that have significant flat feet and ligamentous laxity, it almost looks like they're walking on the inside of their feet, almost like they're walking on their ankles instead of the bottom of their foot. So there's no good data in showing whether or not using braces or inserts will improve just flat feet. But when you have a combination of severe ligamentous laxity in addition to a tight heel cord, I think that there are ways to help that. This is somebody who has a tight heel cord who doesn't have Costello syndrome, and you can see how that's as far as this gentleman can get his foot back. And the question is, surgical release needed to loosen up that tight heel cord? And really, the question is whether or not it's going to really do anything if there's a problem with the bones of the foot. So we have to know if somebody has vertical talus, really to help us explain if just releasing the heel cord is going to do the trick. So a vertical talus is really a foot deformity that you have to diagnose on x-ray. And it's a rigid dorsal dislocation of the navicular on the talus. And basically, bones of the foot are not in the right place. And here is a picture of somebody with a vertical talus, and you can see how it's this rocker bottom foot. And that's why I think a lot of people think Costello syndrome have vertical talus, because if you look at their foot, they have this very prominent heel, very flat foot. But I don't know how many have true vertical talus. It really, you need to have an x-ray to know if it's vertical talus. And I think it does require a different type of surgery when you talk to your orthopedist about your heel cord in combination with whether or not you have a vertical talus or just the loose lax joints. So here's, you can kind of see how people would think maybe you had a vertical talus with that kind of rocker bottom type foot, very flat foot. So I think that the foot really does cause a lot of problems in Costello syndrome and functional issues with ambulation. A lot of people use the ankle foot orthoses. I think this is another very individualized thing, and really these ankle foot orthoses just help stabilize the foot. There are different types. There's rigid ones. There's flexible ones. Usually the indication for use has to be weakness, hypotonia, joint instability. And it may be that you need to use these AFOs just for some period of time as they start to learn to walk and they're getting more stability, and maybe they won't need to use them later on, because if you immobilize too much, then you start to lose a little bit of your muscle mass. So it's a delicate issue on knowing whether or not you have problems with your joints. And so one of the questions really, I think, is getting a gait study to look and see how they're walking, to see if you need a specific type of AFO, and look at the other aspects of the limbs like the hips and the knees. And getting it in with a good physical therapist is important. Now comes osteoporosis and osteopenia. Diagnosis is really difficult to make, because if you're short, you're going to have low bone mineral density because you have less bone compared to somebody your same age who is taller. And so it's hard, and you have to adjust for that. And you have to look into that, of why somebody has low bone mineral density. In addition, just because you have less dense bone doesn't mean that your bone's not appropriate for your own body, and doesn't mean that you're not going to fracture. So the structure of the bone is also very important. But we do have, this is really the only technique clinically to diagnose osteoporosis and osteopenia, other than just regular x-ray that they can say it looks like it's not very dense. But is osteoporosis important in the general population? It's important. In fact, it's much more common than heart attack, stroke, and breast cancer combined. And in addition, it costs $14 billion a year. It's responsible for over almost 1.5 million fractures annually. In fact, people that are over 50, and 24% of hip fractures in patients aged 50 and over die the following year after their fracture. So we know that osteoporosis, especially in adults, can have severe morbidity and mortality. And the question is whether or not we can intervene earlier. Do we need to be monitoring? And my main question is, why is this the case? What's the contributing factors to osteoporosis? And the future impact on osteopenia. Osteopenia means that your bones are just less dense, and really in kids that's all we can really say. And we know that you reach your peak bone mass early. We have no studies on fracture rates in Costello syndrome. We don't know if the traditional medicines are going to work well in Costello syndrome. We don't know the impact on the development of scoliosis. And there was one case report of a child with Costello syndrome, and you can see the spine right here. And this is the development of scoliosis within a couple of months. And the patient was treated with bisphosphonates. It was on growth hormone, developed a rapidly progressive scoliosis over less than a year of time. So I think there's something about Costello syndrome that leads to potential worsening of scoliosis rapidly that we have to keep a close eye. And you as parents just kind of looking at their back and saying, wow, that's really not looking exactly right, and have them checked out by your regular doctor. But what was interesting in this case was that markers of bone remodeling were increased. And that indicates that the bones are being turned over more quickly than what we'd expect. I just need to make sure my time. So yell at me if I'm close. So what causes the bone problems? I don't really know. Is it ligamentous abnormalities, neurologic abnormalities? Is it an abnormality in hormone imbalance? We look at growth hormone, we look at many other hormones, and hormones do dictate how your bone responds. But my question is whether or not there could be an abnormality of the cells that make up your bones and that eat away at your bones. And in the previous case, they showed abnormal markers of bone metabolism. So it would indicate that your bones are being turned over more quickly than what we would hope. So here's a picture of what osteoclasts do. Osteoclasts are cells in your body. They lay down on bone. They release chemicals. They eat away at the bone. And then osteoblasts come back and they build back your bones. So all of our bones are being constantly remodeled and turned over again. And so it's a delicate balance on your bones of how your osteoclasts work and how your osteoblasts work. So we need to look at these two cells to give us an idea of what is causing the problems in the bones, and to see if it is a problem with the function of the cells or if there's something else that we need to look at. So sadly, I don't have any data on Costello syndrome yet, but you guys are all helping me out to figure out if this is the case. But I wanted to present some data on a syndrome that's related to Costello in the same pathway that really gave the impetus for us to now look at it in Costello syndrome in terms of osteoclast. So here is a normal tibia. This is a child who died from a motor vehicle accident. And if you look at the bone of the tibia, it looks pretty normal. It doesn't look porous. But here is a piece of bone from a child who has neurofibromatosis type 1. And if you can see, the bone is very ragged, unusually shaped, very porous. Here's another tibia of a child with NF1, and you can see how it just kind of looks like cottage cheese, or Swiss cheese, not cottage cheese, but kind of Swiss cheese, little tiny holes. And then I took cross-sections of these bones, and here's the control tibia of somebody without NF1. And if you look at, this is cutting through the cortex of the bone, and you look at 3 other patients, individuals with NF1 who had tibial pseudarthrosis, where the bone bowed and break. You can see that the cortex, which is supposed to be pretty solid, is really abnormal, and you wonder how that bone even stands up. And you can see that the wider it is, the more dense it is, and if you look up there, the bone is more grayish and looks less dense. So one of the ways that we can look at markers of bone resorption is from the urine. And that's part of what I've been doing on a research basis, is looking at the bone when those osteoclasts eat away at that bone gets broken down, and then the cross-links between the collagen gets excreted in the urine. And the body tries to get rid of it in the urine. So what we do is measure to see if those cross-links are increased. So if you have increased amount of these cross-links, that means that your bones are getting broken down more, or at a faster rate. So a marker of bone resorption. And here is what we see in NF1. The bottom is control individuals who do not have NF1. The middle group are those with NF1 without a bone problem, and the top group are NF1 individuals who do have a specific bone abnormality like scoliosis or tibial bowing. And so the higher you have means the more your bone is being resorbed. And you can see that it's statistically significant and increased in individuals with NF1. And my theory is that in Costello syndrome, this is also going to be the case, that we're going to see higher markers of these bone that is being resorbed more frequently than what we would anticipate. In addition, we can look at these cells called osteoclasts. So I take a blood sample, we then get these specialized cells, and then I take them and I put them on a dentin slide. And a dentin slide is basically just a piece of bone. So we have this little piece of bone, we put these cells on the bone, so we get that from the blood, culture them out, we put them on the bone, and then those cells still are hungry. They want to eat away at that bone, so they keep eating that little dentin slide, and we can measure the actual pit size of the dentin to see if the osteoclasts are hyperactive. And here is somebody, osteoclast, who does not have NF1, and then you can see over here the osteoclast of somebody with NF1, and you can see how big this resorption area is. There's these huge pits, where here you have these little tiny pits. So the osteoclasts are just ramped up, and they just want to eat away and break down all the bone. And this is when we measured the actual size of those pits, and they were increased in NF1. We actually looked at the cells under the microscope, and in NF1 we had a lot more osteoclasts, very big. They had a wider belt, that means that they can attach to the bone more easily. And so our future direction is to look at other syndromes of the RAS pathway to see if it correlates with Costello syndrome. So right now we're hoping if the osteoclasts are ramped up and hyperactive, then using bisphosphonates seems like a good treatment, because bisphosphonates inhibit osteoclasts. They block the action of osteoclasts so that the osteoclasts don't eat away at your bone, and so the bone doesn't get resorbed. So there are also other drugs that do the same type of effect that work in the same pathway, and so there may be other drugs, if it works in NF1, we can then use it in Costello syndrome. Because it's going to be very hard to do a drug trial in Costello syndrome versus NF1 because there's so few patients with Costello syndrome.